Hello, welcome to Wellness and Wisdom with Dr. Nadu Tuakli, the podcast dedicated to empowering women over 40 to age gracefully, competently, and beautifully. I'm Dr. Nadu Tuakli, a family doctor, preventive medicine specialist, author, teacher, mother, and expert in hormone replacement, anti-aging, and longevity. With decades of experience as a physician and as a woman embracing every stage of life, I'm here to share practical advice, expert insights, and inspiring stories to help you thrive in happiness, health, and appearance. Together with my guests, we'll explore topics that matter most to you, from navigating perimenopause and optimizing your health to redefining success in retirement and beyond. Let's celebrate the aging process with vitality and purpose, because your best years are still ahead. Subscribe now to add more life to your years and step into the best version of yourself. So, nearly half of adults have it, and most don't even know. Hypertension is called the silent killer for a reason. Learn how to spot it, stop it, and take control of your health in my latest podcast today with cardiologist Dr. Catherine Benziger. Welcome to Wellness and Wisdom with me, Dr. Nadu Tuakli, where we cut through the noise and focus on what really matters to your health. Today, we're tackling the silent threat that affects nearly half of all adults: hypertension, otherwise known as high blood pressure. You may not feel it, but it works quietly in the background, raising the risk of heart disease, stroke, kidney disease, and more. The good news: high blood pressure isn't destiny. With the right approach, it can be managed, prevented, and even reversed. In this episode, we'll uncover what really drives hypertension, how to spot the hidden warning signs, and most importantly, practical steps you can take right now to protect your heart and live longer, stronger, and healthier. So as I mentioned earlier, I'm joined today by Dr. Catherine Benziger, a board-certified cardiologist and medical director at Heart and Vascular Research at Essentia Health in Duluth, Minnesota. She is also a fellow of both the American College of Cardiology and the American Heart Association. Dr. Benziger is passionate about advancing heart health in rural communities, especially through prevention and education around conditions like diabetes, high cholesterol, and today's topic, hypertension. So while we dive into the silent killer, our next episode will continue the conversation by unpacking cholesterol. What's good, what's bad, treatments, statins, and more. So I hope you'll tune into the next episode as well. But without further ado, welcome Dr. Benziger. And thank you so much for joining us.
Thank you so much for the opportunity to talk to you and your listeners today about this really important and very prevalent topic, high blood pressure, also called hypertension.
Right. So for those listening, let's start real simple. What exactly is hypertension and why is it such a big deal?
Hypertension is our medical term for elevated blood pressure. It has to do with the pressure in the blood vessels in your body. The top number we usually call the systolic blood pressure. That's when the heart is pumping. And the bottom number is the diastolic blood pressure. And that's usually when the heart's at rest. And about half of adults, as you mentioned, have this, and many don't know that they have it. And often there are no warning signs or other symptoms, but it does lead to other conditions like strokes, heart attacks, kidney disease, and more. And so it's super important to get your blood pressure checked regularly. When you go to the doctor's office, you go to the dentist, you go to your local supermarket if they have a cuff, or to get a blood pressure cuff yourself and know what your blood pressure is.
So the ACC, that would be the American College of Cardiology, came out with guidelines, new guidelines in August 2025. And why do we even need guidelines?
These are really important guidelines by our professional society, the American College of Cardiology and the American Heart Association, that really help all family practice providers, all your primary care docs, internal medicine, cardiology, all practice based on the best evidence, the best research that we have. And there's been a lot of research that has gone on in the past decade. And so we needed to update these guidelines from our prior recommendations. And these are what help a lot of our hospitals determine what quality metrics that they're going to track and how they're going to try to improve population health and make sure that population is staying healthy and well and free of these types of diseases. So these were just released in August 2025. And again, they're defining elevated blood pressure or hypertension, stage 1, the first stage, at systolic blood pressure over 130 and a diastolic blood pressure over 80. And then we call stage 2 hypertension over 140 over 90. And so these cutoffs are the same, and it actually goes down to age 13. 130 over 80 is the cutoff for high blood pressure, even in adolescents and younger adults. And it's really important to know what your number is, to have it rechecked. And if you have 3 or more elevated blood pressures, at least 2 weeks apart, then you get this diagnosis of hypertension. We really use these guidelines then to say what is the gold standard in terms of management, and really what these guidelines are emphasizing and what we continue to know is that lifestyle is number one for trying to improve the blood pressure once you get this diagnosis. But there are certain groups of people who are higher risk for developing some of these events, these strokes and the heart attacks and things, that we need to be more aggressive in treating their blood pressure earlier and not sort of just wait and see, let it go, try doing, some lifestyle changes and we'll, see you in a year. We really need to be much, much more closely monitoring these people who have these risk factors so that we can get their blood pressure under 130 over 80. So less, like in the 110s, 120s is really where you want to be, especially if you're someone who's had a heart attack, a stent, bypass surgery, a stroke, a mini stroke, or we have this new calculator that the American Heart Association came out with a couple years ago called the Prevent calculator. And if your Prevent risk score is over 7.5%, we also consider you to be high risk. And a lot of times these are people with diabetes or who have a lot of other risk factors. So that's what the guidelines are really outlining. And they also tell us about what other lab tests that we need to do and what are the first, second, third line medications that we should use to treat that.
Okay. So let's say someone wants to monitor their blood pressure themselves at home. What kind of monitor should someone look for if they wanted to buy one?
I think there are so many different blood pressure monitors available. I think the best one is the one that you use. I see a lot of people who have them and aren't using them. So whatever one you're most comfortable with is the best one. A lot of times we recommend the automated cuffs that are on the upper arm, that those seem to work well. There is a website called validatebp.org that will list hundreds of blood pressure cuffs that have been studied in clinical trials and used that are validated. Most of the blood pressure cuffs you'll get at pharmacies around the country are on that list. If your blood pressure cuff is old, over 10 years, it might not be working quite as well, and you might want to consider getting a newer one. But again, the most important thing is if you have high blood pressure, you've been told you have high blood pressure, or you're on medications, I think it is very important that you have a blood pressure cuff at home and that you're using it. The guidelines actually are recommending that you take 2 readings, at least 1 minute apart, 2 times a day. So 4 readings total if you are diagnosed with this problem, to keep an eye on it and see how you're doing with your lifestyle changes at home. And if it continues to be high, then you may need to be on medications. So our home monitoring is checking it twice in the morning and then twice before bed.
Now, are they going to have to monitor their blood pressure? 2 readings twice a day for the rest of their life?
No. It's just when you get diagnosed or you go to the dentist, sometimes they check your blood pressure and they say, oh, did you know you had high blood pressure? Especially when you're trying to work on some lifestyle changes, it's really amazing. You can really get some good feedback after you've eaten a salty meal and your blood pressure is much higher than it should be. Sometimes it's good feedback to know maybe I shouldn't be eating those foods and cutting back on salt. So it's not something that you're going to need to check twice a day forever. But I think when you get this diagnosis and when you're trying to get it under control until you get it down below 130 over 80, I think it is a good idea at least once a day to keep an eye on your blood pressure.
Now, speaking about the blood pressure monitor, I actually tell my patients to buy one that has a memory. Because sometimes the cheaper blood pressure cuffs in the pharmacy or whatever don't have a memory. And so they do the blood pressure, and before they find a pen to write down what it was, they've already forgotten what it was. And, or if they come to the office and you want to have a record of what they've been. So I have them journal their blood pressures, but they say, I keep forgetting and I don't remember. I think it was 130 something. Mm-hmm. So I always tell them that a blood pressure cuff with a memory is helpful. Plus, they can bring it in. We can see what the blood pressures have been.
I completely agree. I think if you have the funds and you can pay a little bit more for your blood pressure cuff, there are some nice apps that will track that you can download onto your smartphone, and then you can track it, you can graph it. Some people are very analytical. I have some, retired
Yeah.
engineers that have spreadsheets and have, all these numbers tracked, and they can correlate with, what they're eating and their activity level and things. So I think it is important to write it down, whether it's automatically being recorded on an app and on the machine, or you have a piece of paper, a notebook, a journal. It's important to write it down so that you can bring those blood pressures. Usually I tell people to do it for at least 2 weeks, at least once a day. Like I said, the guidelines are saying really if you're doing home monitoring, we should be doing 2 in the morning and 2 at night. And that would give us actually the best picture of your blood pressure over the course of, you said, a couple weeks.
Now, are there certain times of the day that give the most accurate reading?
Blood pressure can vary throughout the day, and it also can vary based on activity and what you're eating and things. So usually we recommend doing it first thing in the morning. Empty your bladder, go to the bathroom, try to sit for 3 to 5 minutes. The guidelines say at least 5 minutes without watching TV or being on your phone or having a lot of stimulation. Don't have just exercise, like do it before exercise. And then also they recommend checking your blood pressure before you have any caffeine or alcohol or nicotine. All of those things can really cause false readings or cause elevated blood pressure that may not be accurate.
So, someone has been told that they have quote unquote borderline high blood pressure, which obviously that borderline has kind of shifted a little. But what are the first steps that they can do before start taking medication?
Again, the guidelines are really emphasizing lifestyle therapy for most people who don't have clinical cardiovascular disease. So for those folks who have stage 1 hypertension, again, who don't have a prior heart disease history, they can start on just lifestyle. Heart healthy lifestyle includes foods rich in fruit, whole foods, fruits, vegetables, whole grains, lean protein. We recommend the Mediterranean diet for some folks. That's more fish and olive oil based, very little dairy and meat and sweets. Some people prefer more of a vegetarian diet. There's also the whole food plant-based diet, which really avoids all processed foods. Really what you're trying to get at is cutting down on salt and processed foods. And the DASH diet, which is the dietary approach to stop hypertension, which is recommended by the American Heart Association, really says limit the salt to at least 2,300 milligrams, which is about like a teaspoon. And ideally, they want 1,500 milligrams, 1.5 grams or less of salt a day. And most Americans are eating between 4 and 5,000 milligrams of sodium a day. And people constantly are telling me they're not adding salts, at the table, but the problem is it's just in so many foods. So
It's in the food.
Yep. And I like to talk about the salty six. The six things that I think people get the most sodium are breads and rolls, pizza, sandwiches, cold cuts and cured meats, soups, and then like burritos and tacos. So for kids in particular, young adults, those are the salty six that you really need to cut back on. And I can tell you my kids, that's what they like to eat.
That's the stuff
Fortunately,
they
their
like.
blood pressure isn't high right now, but adults have to be careful with those things as well and find lower sodium options, read labels, trying to cut back on the cheese and meat and processed foods, I think is really important.
So, what about potassium salt substitutes, the ones that are no salt but equivalent
Yeah,
potassium?
there's been more randomized control trials showing that those potassium substitutes are actually beneficial and they don't have the sodium or the part that raises your blood pressure. And those are actually can be good for you. Now, there are people who have kidney disease or are on certain medications that also can cause high potassium. So I think it's important that if you're going to be using these salt substitutes, that you're just making your primary care physician or provider aware of that and just make sure that you're getting your kidney function and potassium monitored because you can run into dangerous levels of potassium if it gets too high.
So, do diet, exercise, stress, and sleep really affect the blood pressure, or is this just busy work for patients to do before they get started on medication?
We know that if you lose weight, for example, for every pound that you can lose, your blood pressure will go down like a half a point. So for 10 pounds of weight loss, you can lower your blood pressure 5 millimeters of mercury. It's like equivalent to a medication. Exercise
Significant.
also, right, can lower blood pressure 8 millimeters of mercury. The DASH diet, right, this American Heart Association recommended diet with limiting the salt has been shown in multiple studies to lower blood pressure 5 to 10 millimeters of mercury. Salt alone, just eliminating the salt is like 4 or 5 millimeters of mercury. So these are definitely been shown in trials to lower blood pressure basically as well as a medication. It's the adherence that's the problem. Getting people to follow through and sustain these lifestyle changes over not just weeks and months, but years has really been the problem. And so then that's when we end up sometimes recommending medications if we can't get their blood pressure to be consistently below 130/80.
Now, the DASH diet that Dr. Benziger is referring to can be found online, and it is DASH. It is not the same as Mrs. Dash, the flavor thing that you put in your food, but it's an actual dietary interventions for hypertension. So DASH, that's what we're referring to. Now, can things like coffee, alcohol, or even supplements raise your blood pressure? I get asked about coffee all the time.
These are great questions. So most people have what we call essential hypertension or primary hypertension. It can be just due to some of their lifestyle habits and things and diet. But other people can have something called secondary hypertension. And secondary hypertension is blood pressure that's elevated because of another reason. And if we treat that other reason, maybe they don't need to be on these medications and things. So the biggest one that I like to make sure that people are aware of is sleep apnea. Undiagnosed and untreated sleep apnea is one of large contributor to uncontrolled high blood pressure. But medications are another one. So sometimes another cause of secondary hypertension can be some over-the-counter medications that people don't even realize affect blood pressure. So salt-containing antacids, if you're taking a lot of medications for reflux and things, that can cause high blood pressure. Smoking and nicotine use, even chewing nicotine, that can cause high blood pressure. Alcohol is a big one. NSAIDs like ibuprofen and Proxen and things that we use for pain. We recommend if you can use topical or use Tylenol or acetaminophen, having long, or if you have to use it, using it for a shortest duration possible, not being on it kind of daily forever. Those are really important. Other over-the-counter medications like decongestants, nasal decongestants are another one that can raise blood pressure. So again, using it for the shortest amount of time. There are also herbal agents like ephedra, black licorice, mahuang, and others that are also can interact. And then oral contraceptives for women are another one that in some people can really lead to high blood pressure. So if you're having a high blood pressure after being prescribed contraception or hormone replacement therapy and stuff, something to consider is being on a lower dose for the birth control, even a progesterone only or IUD or other forms that are lower estrogen would be recommended. And then obviously drugs, are bad. Meth and cocaine, those can cause high blood pressure. We recommend avoiding using recreational drugs. Those are important things that we should, as physicians, ask patients about so that we're not adding additional medications when we could be taking away things that they're taking that are contributing.
And a lot of patients also don't realize that when there's a D after the name of the medication that they take over the counter, like Tylenol D or Benadryl D, the D is usually a decongestant. And if you stay on it too long, you are going to raise your blood pressure.
And then you asked about caffeine. And so the recommendation for caffeine, it's a little controversial. A lot of people like their caffeine in the morning. I think the guidelines do formally say limit caffeine to 300 milligrams a day. I think it depends on your choice of coffee and how strong it is. A cup of coffee is usually 80 milligrams. So that's a couple cups of coffee. If your typical drink is a venti espresso at Starbucks, you're probably over the 300.
One shot.
It depends on how much caffeine is in there. So try to keep it under 300 milligrams. There are some energy drinks. And if you go to certain restaurants, these charged energy drinks that are 400 milligrams in a cup, they don't really sell them as caffeine. They say contains caffeine, but you really need to read the fine print and really limit your caffeine intake if this is something that you've been diagnosed with.
So when do you decide it's time for a person to start medication?
That's a great question. I think if the lifestyle interventions have not been working, and usually we try for 3 to 6 months, to talk to people about it. If you have access to a nutritionist and you can really make those lifestyle changes, we give people sort of the benefit of the doubt to try to make those changes, and then we'll follow them up in clinic. And if they continue to have high blood pressure, we really don't want to leave it untreated for a long period of time. So usually by 6 months, if you've consistently had high blood pressure and it's over 140, over 90, and you don't have any other risk factors, you're otherwise really healthy, your doctor would probably recommend starting blood pressure medicine. if the blood pressure is over 130 over 80 and you have these additional risk factors, or your prevent risk score is high, if you have diabetes, kidney disease, these other things that, put you in a higher risk group, then they might recommend medications right away. We still think it's important to do the lifestyle medications, or the lifestyle changes, but we know that medications are also very effective, and we need to kind of act soon and now. So it depends on your other health factors.
So without getting too technical, what are the main types of blood pressure medicines and how do they work?
We have a whole
It's a big one.
lot of medications that can treat blood pressure. So if one doesn't work for you, don't worry. There are plenty of others, just like for lowering cholesterol. It is not like you get stuck in one type of medication. There are 9 or 10 different classes of blood pressure medicines. The guidelines recommend that we use a couple sort of as our first line medications. One group is called diuretics. These work to help get rid of excess sodium in the body, and then they reduces the blood volume by making you pee a lot. So they're diuretics. You have to be close to the bathroom for a couple hours if you're on that medication. Others are ACE inhibitors, angiotensin converting enzyme inhibitors, like lisinopril. It's a very common medication. Blocks the production of this factor called angiotensin 2, which is a hormone that helps narrow blood vessels can dilate. The other one is called angiotensin receptor blockers, or ARBs, like losartan, candesartan, olmesartan. These are also very effective. Those are all sort of the first line. And then calcium channel blockers. Those help by working on the heart and blood vessels, preventing calcium from entering the cells, and then they can relax a little bit. And so amlodipine is one of probably the more common calcium channel blockers. So those are your first, really second, and sometimes third line medications, those combinations of diuretic, ACE inhibitors, ARBs, and calcium channel blockers.
So I noticed you did not mention beta blockers, like atenolol, Lopressor. Why not?
The last guidelines were the first time that they kind of moved beta blockers into sort of your second line agents. They're just not that good at lowering blood pressure. They're good for certain conditions, like people who have atrial fibrillation or having palpitations or fast heart rates. And there's a lot of people who are on them, but they're not as effective at getting the blood pressure under control. So they're no longer our first line, but there are reasons why people do need to be on them.
Okay. So there was a time when the guidelines came out and they said we needed to wrap our minds around the idea that most people with hypertension would be on probably at least 3 medications. And now the guidelines have shifted a little bit. So is it just that we're still giving the patients 3 medications, but we're sort of camouflaging them in combination medications?
The guidelines do find that combination pills are actually more effective at getting people to goal than the single medications. I think at first, when you get started on a medication, sometimes we will start with one and try to go up to the highest dose of that and then add a second one. But there's been a lot of trials that show if you're over 140, over 90, and your goal is to get below 130, sometimes we need to start 2 medications sort of out of the gates. And that can be a combination pill where you're sort of at intermediate doses of 2 medications, and that sometimes that's all you need. So it's one pill, but there's that secretly, like you said, 2 put together. I think whatever combination works for you, and just work closely with your provider and clinician to try to get you to goal. That's really the most important thing, whether that takes 1, 2, 3, or sometimes 4 medications. There is a whole section in the guidelines. If you are on 3 medications and your blood pressure is still not well controlled and you're taking them as recommended, or you're on 4 medications for blood pressure, you have what we call resistant hypertension. And there is a new therapy that some people are starting to look at using called renal denervation. And it's a way to go in and affect the nerves in the kidneys. And they go in using a catheter. And that's now in the guidelines and as a possible treatment option for people who have just really stubborn high blood pressure despite all of these lifestyle changes and medications.
Now, one of the advantages of the combinations is that you can use smaller amounts of each individual medication as a combination and still get your results versus having to give them full strength or full dose of each medication. So there is an advantage sometimes to using a combination. So if your doctor offers you a combination medication right out the gate, there's probably a reason why.
Yeah, and I think if it's affordable for you, I think that's great. Again, it just depends on, unfortunately, in the United States, your insurance and what your copays are. Sometimes those combination medications can be more expensive than the two individual medications. So I would say whatever you're going to take, sometimes once a day medications are easier for people to take than things that need to be taken twice a day. And so we just need to work together. Some people really cannot take a diuretic. They have a job that has them truck driver across, not readily near, bathrooms. Like that's not a good therapy for someone who's on the road a lot, for example.
So many people worry about side effects. What should patients know?
I think anytime you start any new medication, it's important to know what are some of the common side effects and things to look out for. And if you have any of the common side effects, the first thing to do often is to stop the medication and make sure that those side effects go away. If the side effects go away, often I recommend trying to restart the medication. Sometimes you have to start it at a lower dose. Usually people reach out to their, whoever ordered the
Right.
medication just to make sure that, if there's anything else that they should be looking out for. Sometimes there's a lot of things that can cause some of these side effects. So sometimes it's not definitively related to the medication. But then if you restart it again and then the same side effects come back, at that point I would say, okay, you clearly can't tolerate this medication. We're going to add it to your allergy list or intolerance sort of list, and we'll try something else. So I think
There's
it's,
always something
yeah,
else.
that's right. We have a lot of different options. In my mind, if you have high blood pressure or high cholesterol or you have diabetes and you can't tolerate medications, don't give up. Try to find someone who will get you on something that will get those numbers under control. That is the most important thing. There's a lot of different ways to get there.
So I find sometimes patients are resistant to starting blood pressure medication because they've heard a rumor that once you start blood pressure medicine, you can never come off it. And so they're like, oh no, I don't want to start. Am I going to be on this for the rest of my life? And, sort of catastrophic kind of idea about it. And I oftentimes will tell them, hey, we're going to deal with what's in front of us right now because that's important. It's causing damage to your body. But should you lose weight, you start exercising, you do different things, it is possible to come off blood pressure medicine. Is that true?
Exactly. Yeah, this is not a lifelong medication. Some people who have, for example, genetic high cholesterol or something, yes, they were going to need to be on probably medication for the rest of their life. Usually, blood pressure is not genetic. It is usually largely driven by lifestyle and your diet and physical activity and weight. And I think if you are able to address those things, there are also new medications for weight management. And I think a lot of people are finding that they're able to lose weight easier than they were in the past, and they're eating less salt, and they can come down on some of their other medications for their diabetes or blood pressure and things like that. And some people potentially could come off of those if you really, really eliminate salt. That is probably one of the biggest contributors, that and alcohol. I think for men, I see that a lot. You could come off some of these medications if you make those more
If you
dramatic
really
lifestyle
try, willing
changes.
to
Yeah.
make the difference.
Mm-hmm.
So, if you've been diagnosed with high blood pressure, how long before you start to get end organ damage? Is there any kind of idea of from the time you have elevated blood pressure to when your kidneys and eyes and all the other organs start to show signs of it?
It really has to do with how high your blood pressure is and how long you have it. And there's some natural variation that can happen during the day and at night. Strokes tend to happen more in the early hours as people have, with cortisol levels changing, seems to have higher blood pressures in the evening and night times. Uh, it really does, it is a cumulative effect over decades. Most older adults tend to have high blood pressure because of damage that was done cumulative fashion in their 20s and 30s and things like that. So I think the sooner that we address this, the sooner that we can prevent some of that long-term damage that can happen. But it can happen. People in their 30s, even 20s, can have strokes because of undiagnosed extremely high blood pressure. And that can be very, very devastating for a young person to have a stroke and not have the ability to use half of their body because of a blood pressure problem that was very preventable.
Right. There was a rumor once upon a time that if you were older, you needed a higher blood pressure
Hmm.
to push the blood through those hardened arteries, especially to the brain. Do the guidelines say anything new about blood pressure in older adults?
I think we used to let people's blood pressure creep up too high in older adults. And now we know that people are living longer and they want their brain function. They don't want to have dementia and have memory issues. And a lot of dementia these days is related to vascular disease and having clogged arteries and high blood pressure and thickened arteries. And so we do find that people actually who have lower blood pressure, it's treated to a lower number, actually have better mental capacity and have lower heart attacks and other events and can live a healthier life even if they're an older adult. And so we no longer recommend blood pressures of 160 over 100 or these high numbers. We still want our older adults to be usually in the 130s over 80s or below, especially if they've already had a stroke or heart attack. But even if they haven't and they're otherwise pretty healthy, we are still more aggressive than I think we were in the past because of the new research showing that it is beneficial for brain function and preventing dementia.
So if we have someone in their 80s and their blood pressure is 130 over 80, we can accept that?
I think you can accept that if they are someone who is living at home and doesn't have any significant kidney disease and heart disease. I see a lot of people in their 80s who are in the hospital with heart attacks. We would try to keep that at or below 130 over 80 in general. The problem with older adults is that they can be more prone to developing orthostatic hypotension and falls can be, more debilitating. You can break your hip, you can hit your head. If you're on blood thinners, you can have bleeding. So we don't want the blood pressures to be too low that they're getting lightheaded, dizzy, and passing out. But usually we're monitoring the blood pressures on a regular basis, and we're using kind of the lowest doses that we need to get to that desired effect. We won't have as much of those low blood pressures.
So what's the biggest myth about hypertension you wish people would stop believing?
The biggest myth that I have heard is that it doesn't exist and that they don't have a problem. Because
Denial.
I think the denial is the hardest thing to overcome. It's easy for me to write a prescription. In the computer these days, everything's saved. It takes 10 seconds or less. But accepting that you have a chronic condition and doing the hard lifestyle changes is really difficult for people. And that's where we really need people to focus to be able to get this problem under control. The medications is the easy part. It's sort of a band-aid, but it would be better if people recognize that this is a huge public health problem. We're not just coming out with guidelines and making up numbers because we want people to take medicines. We want people to be healthy. We want people to stay out of our emergency rooms and out of the hospital and not need as many procedures and lower the cost of care. And the way we do that is by preventing all of these things. And this is where the research has shown lower blood pressure, lower cholesterol, having normal weight, having 7 to 9 hours of sleep, getting 30 to 60 minutes of physical activity every day, eating a heart healthy diet. These are sort of the American Heart Association's life's essential 8 factors that if you can maintain that, you will not need to see a cardiologist, hopefully ever. And that's our goal. So I think the denial is the biggest piece that is
I
frustrating.
think you're one of the rare cardiologists that would like to put themselves out of business.
I would love to be out of a job. That would be great. Unfortunately, with tobacco still being quite prevalent in my communities, that's not something that I think is going to happen.
A little bit of a dream, huh?
Yeah, and I think we continue to have this obesity and diabetes epidemic. We've sort of stabilized our weight trajectories, but kids are still
Oh,
increasing in
yeah.
their weight at an exponential rate that we've never seen in any of the prior generations. They're not as physically active in schools. They're not doing extracurricular activities. They're not playing at the parks. They're on screens a lot more than any other generation. And I think we're going to continue to see problems with high blood pressure starting at a younger and younger age, teens and adolescents, young adults, that is going to accelerate heart disease and all these complications if it's not addressed.
So if someone's blood pressure is high just once at the doctor's office, how do we know if it's white coat hypertension or something real? Is that when the person needs to go buy a monitor and do some home monitoring?
Usually we say you need 3 different elevated blood pressures. And usually in the clinic, we always recheck the blood pressure because sometimes not as accurate the first time. You haven't been sitting for the full 5 minutes. You just rushed in from the parking lot to get to your appointment on time. So if the recheck blood pressure is elevated and it is elevated again the next visit and the third visit, even if it's with different people or it's at the dentist, if you continue to have elevated blood pressures, I would be concerned. If it's a one-time thing, I think it's just important to take note of that, mental note of that. And again, try to continue to be as heart healthy as possible. Try to get that daily walk in. Most people need to exercise 30 to 60 minutes a day, which most people have to go for a couple mile walk if they don't have routine exercise as part of their commute or part of their daily activities. A lot of people live in suburban areas and car dependent places, and they're not getting routine physical activity as part of their daily life. And so exercise and diet, if you have ever been told you have high blood pressure, I think is a good first step.
So what should someone do if they get a very high reading at home? What number should make them call their doctor immediately or go to the emergency room?
Usually we tell people over 180, over the top number over 180 is very concerning. And then the bottom number, usually in the 100s, over 110, I think is what they would recommend. If you're not having any symptoms, you could potentially call like a nurse care line or your doctor's office and talk to a nurse, and then they can help you decide if that's something that needs to be seen urgently in the emergency room, or if you can schedule an appointment in the next week or so to be seen. If it's a one-time reading, that's different than if it's consistently high. And if you're having any visual symptoms, any headache, any chest pain, any other associated issues, then definitely need to go to the ER. If the top number's in the 200s, particularly anything over 220, that is extremely elevated. You definitely should go to the emergency room to get checked out because you're at very high risk of having a stroke.
So if you could give listeners just one takeaway message about managing their blood pressure for life, what would it be? Lifestyle changes.
It's all lifestyle. I'd say it's not just one thing, but move more, sit less, eat healthier, whole foods, know your numbers. It's all the heart healthy lifestyle. I say prevention is really the best treatment. Not having high blood pressure is the best way to treat high blood pressure. If you need it treated, take your medications and get a blood pressure cuff so you can make sure that it is well controlled.
Great. Well, Dr. Benziger, thank you so much for joining us today. It's nice that you could take the time to be the cardiologist on the spot. And I hope to talk to you soon about the cholesterol, because that's another question that patients have a lot.
Yeah, definitely. Thank you so much for the opportunity. And I hope useful information for your listeners. We'll look forward to talking again soon.
Thank you for joining me today on Wellness and Wisdom. I hope this conversation with Dr. Benziger give you a clear, practical tools to take charge of your blood pressure and protect your heart. Remember, hypertension does not have to be a life sentence. Small daily choices, what you eat, how you move, how you manage stress, can make a world of difference. But our journey doesn't stop here. In our next episode, we'll tackle cholesterol. What's good? What's bad? What do those numbers really mean for your long-term health? You're not going to want to miss it. If you found today's discussion helpful, be sure to subscribe, share this episode with someone you care about, and leave a review. It helps us to reach more people who want to live longer, stronger, and healthier. And for more resources on staying well at every stage of life, visit me at drtuakli.com. Until next time, I'm Dr. Tuakli. Stay well, stay wise, and remember, rooted in science, guided by care, committed to lifelong wellness. Bye.